This meeting is now being recorded.
Hi everyone, this is Chris McCracken. I hung up on you. Apologies. So I see we've got you trained well and everyone is entering their agency name in the chat box. Thank you very much. But today we're going to start our new process. I'm going to wait a little bit for people to chime in. Back on. Help her minute. Hello. Hi. Hey, don't forget everyone, star 6, mute yourself. Okay. Thank you. Okay. Hi, this is Chris McCracken with Women's Wellness Connection. This is the HIT call. It's making sure you're on the right call. We're going to talk about two things today, two kind of separate topics, but they're both pretty critical to you in the next few months. So I'm going to let everyone in the room introduce themselves next.
Hi everyone, this is Angie Fellers-Lemire. I'm the nurse consultant for WWC and Wise Woman.
Hi, I'm Marina Milder. I'm the data manager for WWC.
This is Ivy, program coordinator for WWC Clinical Services and Wise Woman Program.
This is Shannon Lawrence, evaluator for
All of WWC and Wise Woman.
And Sarah Jestra, program assistant.
Thank you, everyone. Again, I want to remind everyone to please star 6 to mute your phone. It's all the background noise from coming across, and star 6 to unmute yourself. I'm going to start today's HIT call by talking a little bit about our new progress report and our new, it's a new report, it's a new process for you and for us, and I wanted to give you a chance to ask questions, and I also wanted to give a little background as to what our decisions. Oh. Nope. So you should all have been given or received a worksheet for the progress report, and we know that some of you actually have started working on this, and that's great. A couple things to tell you right now. The link to the actual survey itself is not completed yet. You'll see where it says insert website here. We will be sending you the final version of this document in the next few weeks. The other piece that some of you have discovered is that eCaST isn't quite ready to run those reports that we referenced. So again, we will let you know when those are ready. Definitely by November 1st will be our final day for that. So this report for what we'll call the first performance period does cover the first part of the fiscal year, and so it goes through October 31st. And it will be due back to, or not back to us, you will need to complete the survey by November 16th. We found that if we do this kind of worksheet to write down your information on, to collect your information, you may, it'll be a little easier when you do that entry into the survey. Two other things, 2 opportunities for training on this process. We're creating a video and that'll be posted on our website. And we're also going to demo the actual survey at our roadshows. So if you're not going to roadshows, never fear, you will also. I'm hearing some feedback from myself, so just *6, help that.
Yeah, just be sure you *6 to mute yourself.
Yeah, unfortunately. Every. So if you're going to a roadshow, you'll see a demo of this survey. We're going to show it to you, and we're going to show you how to run the reports and eCaST and that kind of thing. But even if you're not going to a roadshow, that we will have this recording on our website. A couple things you'll need to coordinate within your agency because we only want one submission per agency. So keep that in mind too. We asked this question right here about the clinical services contract because this survey is for clinical services contracts and care coordination contracts. So just so you know, we have a couple agencies that have care coordination contracts only. Most agencies have both, but these two agencies only have the one. Okay, sorry. Can someone *6? Oh, no. Yeah, we can *6 everyone, or we can mute everyone. *96.
All guests have been muted. You can unmute your line by pressing *6.
Okay, great. I wanted to give you a little bit of the background on why we decided to do this. A smaller group of us met in a few months ago. We started 6 months ago, maybe even, to try to make our processes more meaningful and actually to lean them, to make them more meaningful and easier for our agencies. So we wanted so one of our goals for this project is to increase your ability to make changes throughout the fiscal year that enable you to maximize your volume of screening and your quality of screening. We're working on streamlining our reporting expectations across WWC, so this is one reason we're combining clinical services and care coordination in one report tool. At this time, Wise Women is not part of this, but it possibly could be part of this same report tool in the future. We're going to have 3 report-in periods throughout the fiscal year, and we feel like the dates we've chosen for this year are meaningful for collecting and sharing data that we quite often do using multiple venues, multiple communication methods. So the first reporting period is June 30th through October 31st. The next reporting period will be November 1st through March 31st. And the final one will be April 1st through June 29th. So agencies will be requested to submit surveys and responses 3 times a year. I think the questions will not always be all the same. They will be focused on the kinds of data that we want at that time of the year. And they always are asking for your feedback and for your communication with us. I think I think is one of the pieces I'm most looking forward to is asking you about your struggles and your successes and just trying to find out and learning from you more frequently what's going on in your agency. agencies. At the end of the fiscal year, so in August actually, after that final bill run and all of that, we will also be sending you a progress report. We haven't decided what that looks like yet, but it will give you an idea of that how did you do in this entire fiscal year, and that's what will happen. So I'm not going to go through the entire, I'm not going to go through bit by bit and what we're looking for and that kind of thing, because that's really up to you. I hope that most of you had a chance to look at this document before this call, and we really wanted to be able to answer your questions and maybe even, well, and here's suggestions if you have any about this process. I know you haven't even gone through it yet, but maybe some initial thoughts on that. So if you have anything that you'd like to share or ask, *6 your phone, and we'll do our best to answer. I'm just going to scroll through the worksheet for now.
This is Ivy. If you have not read your blog post of this report, or if you have not seen the WWC update, make sure you communicate that to your WWC coordinator as well. We are giving due notice that this report is due in November and have been giving every opportunity for review. So if this doesn't sound familiar at this time, make sure you reach out to Chris or Flora or myself, and we can direct you to where the blog posting is and where the instructions are as well.
I wanted to take a quick mention of the data entry piece. There is a question for clinical services and care coordination. And you don't need to know exactly your data entry percentage at this point. You can ask us. You can contact Flora or Ivy or me. But you know, your best guess, I mean, you may know, especially if you are the only data entry person at your agency, that, hey, this is really tricky for me this year, or it's always been difficult for me, whatever. Please, you know, you are not required to have your exact percentage in order to answer this question. The other one I wanted to mention is this. Attendance. So I'm not taking attendance today. I'm asking you to remember that you were here. And we know that we haven't asked you to keep track of this since the beginning of the fiscal year. So if you need our assistance in refreshing your memory on this for this short period of time, that is fine as well. Just let us know. So what we're going to be doing is, so this is the first period, we're sharing these dates, these are our calls. Yes or no, that's okay. What really matters is at the end of the fiscal year that you meet the requirement of attending 50% of all HIT calls and 50% of all eCaST users group calls. So. Then there's a section for care coordination. Agencies that have the care coordination grant, contract, will need to complete this section. And that includes agencies that are just starting in October. You're just starting. I'd still like to hear back from you. Flora and Ivy and I still want to know, how's it going? Are you getting started? Are you having difficulties getting started? and we want to know what are the areas in which you might need a little more assistance. So that's why I'm asking about this. That's why we're asking about that. That's why it's included in this report tool. Then we have some questions that are kind of generic for all of our agencies. For all the contracts. So, barriers, successes, those kinds of things for all of your contracts with us. Please note this doesn't replace any kind of communication with us that you may want to have. You can call us. Any questions, comments? Star 6.
What questions does anyone have? And I've been getting some text messages of people who have not received the report, so we'll make sure that you get the links and you have everything that you need.
Mm-hmm. They will also be available on our website once they're finalized. Okay. Questions? Sarah?
When is the November due date?
The due date is November 16th because the 15th is a Sunday. And I think we're saying end of business on the 16th.
Let's see. Any news on when the August or September calls will be posted online?
I don't know.
The August hit call is already online, but only the audio version because there was an issue with CenturyLink, and there shouldn't have been a call in September.
But eCaST was
eCaST
in September.
should be online. I can double check that.
eCaST is online right
Okay.
now.
Both the YouTube channel and the.
Okay.
Just a reminder that we only have 6 calls this year, and agencies are required to attend 50% of those calls. So there's not monthly calls anymore.
Not hit calls, yeah.
Not hit calls.
Yeah.
Calls.
It's part of our leaning of our train too.
However, it's a good thing to catch up on all the notes.
Mhm. Yeah, it is. Okay. Any other questions? Okay, thank you. Well then, I am going to share the screen with Angie and Shannon.
Hi everyone, this is Angie Fellers-Lemire. I just have a couple. Sure. I just have a couple. I put the discussion questions on slides for us just so we weren't repeating the questions. So I don't know that. Well, they will be made available as this is being recorded. But so you all, first of all, let me welcome Shannon Lawrence, who is our wonderful evaluator. She is not able to make most of our HIT calls, as she's really working behind the scenes on many different evaluation projects, one of them being the WWC Client ID project. You should have received that slide deck along with a few discussion questions at the end of last week, and I'm hoping that at least most of you were able to review the slide deck and the questions. So welcome, Shannon. We're happy to have you here. Do you want to talk just for a couple minutes about the Client ID project? I know it's hard to do that in a couple
Sure. Well, you know, it might be easiest to give you a little context about why we did this. So 2 years ago, we did the Strategic Directions Project, and that was really when we reached out to you in interviews and focus groups, and also conducted a survey that included WWC agencies as well as other stakeholders in the state, and we were really trying to figure out, anticipating changes with the Affordable Care Act, what you as agencies would need. And among other things, one of the big needs that was identified was, hey, where do we find these elusive WWC clients now that ACA is changing the world? And so what we knew was that the numbers of women screened for WWC was going to go down for clinical services, and they did, about 69% overall. Some agencies saw more or less than that. And then, so what we did with this project was we really wanted to understand what we already knew about women who were eligible for WWC and what were the barriers, why weren't they accessing it? Because we had suspicions based on some census data that there were many more women that we were not screening as a program. And so pre-ACA numbers indicated there were about almost 35,000 women who might be eligible, and even and only about 5,200 were actually screened in the post-ACA environment. And so we anticipate there's about 20,000 women in the state who are not being screened who may be eligible for WWC. And so we did then some focus groups with clients. We did some focus groups with non-WWC providers, and we conducted a survey, statewide survey, to ask women about their kind of health behaviors as well as their understanding of WWC and their financial well-being, and whether or not they anticipated in general, even if they had never heard of WWC, if they thought that they would qualify for a program that provided no-cost breast and cervical cancer screenings. And what we found out was pretty simple. Now, the survey, and that's what this slide deck was mostly about, pretty much what we discovered was that, and we only talked to women who were not eligible for Medicaid. So among those who would have been by income only eligible for WWC, and then we kind of sandwiched that with a little bit of, with women who were a little bit younger and a little bit older. But overall, we pretty much discovered that people did not expect to qualify for WWC. Most of the women who took our survey did have insurance, but still fell within income guidelines for WWC, which suggests that they may be potentially eligible for the Care Coordination Grant Program and or referral in at the point of diagnostics. So, and while this was, kind of not a representative sample of WWC clients right now, because they were mostly insured women, we did learn some things about them, about their health behaviors. We learned about, we also did a little comparison. We looked at our data for WWC women, and the one thing I really did want to point out to everyone, if you haven't looked at the slide deck, was that we discovered that looking at last fiscal year's data, among WWC clients actually screened, 58% of those clients were at or below the Medicaid cutoff level. And that's a pretty important finding as we move forward in the year and as we continue to look at who we're screening and who needs to be screened. So I'll just leave it at there. If you have any questions, I'm happy to answer those, or if Angie wants to talk about the questions that were posed, we can do that too.
Yeah, does anyone, well, actually, let's go ahead and start with the questions since we had 4, but we're really hoping that the next 25 to 30 minutes can be much more of a discussion. And since we have Shannon here to kind of help us answer some of the questions, please feel free to *6 yourself for any comments, questions, or answers. So let's start with the first one. Will any of the findings in the Client ID project change the way your agency is recruiting WWC eligible women? Or have you already changed the way that you're recruiting WWC eligible women and would like to share that with other agencies?
Press *6 to unmute yourself.
Hello.
Yes.
Hi. This is Nora with Valley-Wide Health Systems.
Hi, Nora.
Hi. So we do have various entry points into our clinic system, since we have so many clinics, and we have various entry points of trying to identify whether it's as they come in through the front desk. You know, we've done an awful lot of education with them, and to send these people into our case managers. We have case managers, care coordinators, financial eligibility staff that are all part of the case management system, and they all can refer to those who are enrolling, as well as with our team-based care and patient-centered medical home. We can identify them during the huddles when the teams are having discussions about who they've got coming in that day on the schedules. So we can identify them that way. But the other piece, those have, for the most part, been part of our system overall, but we sort of have intensified the team-based approach more, especially with the huddles. We have specific reports that help identify women or patients who are coming in and giving us different aspects. But the other piece we're looking at is also now trying to educate everybody within the clinic system that if a patient does have insurance, but we get to the point where they've gone through the screening processes and they are now coming into the diagnostic portion, and they have high deductibles for that, that they should be sending them to us to identify whether or not they might qualify at that point for WWC, for the diagnostic work. And that one is taking a little bit more time to get everybody educated, but we are putting some effort into that as well.
That's great, Nora. Yeah, I'm definitely getting more questions about the referred in for diagnostics, and it's been a patient population that you've been able to see through WWC, but we are definitely seeing an uptick of that. So that's great. So Nora, can I ask you a question about your financial screening?
Certainly.
Where in the clinic flow does that fit in? When the patient enters the building, or how does that work for Valley-Wide?
Well, basically, and it isn't so much the financial piece that they're doing up front. What we've taught them to do is identify the age category, and obviously the women. They don't actually see whether or not they would qualify for WWC. If we have a woman that walks in that's within that category, an age group, they are to refer them to our case managers. Now, we do have some financial eligibility. Some patients are coming in for nothing but, at that time, assistance to see if they would qualify either for Medicaid, WWC, or even the health market. And that the staff that's doing those pieces have also been trained, because they're part of the case management staff. If they've got somebody in front of them that could potentially qualify for WWC, they then get referred to our case managers that are actually doing the enrollment. And the same thing with the more advanced care coordinators, as they're seeing patients for the issues that they work with. If they've identified somebody that meets the qualifier, they go and take them over to our case managers. And that's when we actually look at, okay, where's your financial piece? Because our case managers also can do financial eligibility. They're trained to do that as well. So they're coming in. That's why I say we have various entry points. And we also have farm worker services where we actually do outreach for not only the farm worker, but we're doing outreach for other events, for community events. And we also try to ensure that they're also providing information about women's wellness and can refer them. And sometimes we will even send some of our case management staff with them.
Great. Thank you, Nora.
You're welcome.
Anybody have any questions or answers about finding and recruiting these WWC eligible women?
Especially if you have answers, we want to hear them.
Yeah. So Nora touched on, I'm going to skip the second question and go on to the third question since Nora touched on this. Is your agency checking for Medicaid eligibility before enrolling in WWC? If so, or if not, what barriers and successes have you experienced with adding this to the patient experience?
This is Nora again. I'm not trying to monopolize honest.
Okay.
One of the things we have found is it has become very, very important for us to try to, as soon as someone is placed on Medicaid, because we are on the electronic system, to ensure that that enrollment has been updated in our financial stream. Because what we find sometimes is if a patient goes somewhere that's customarily out of our system or the workflow that we normally see and gets on Medicaid and someone doesn't update that information, we have had patients who have been enrolled in WWC and then we have to do cleanup because they end up with Medicaid. The other piece is sometimes we enroll people on WWC because at that time they're not on Medicaid and then later on they become eligible. So that's been one of the biggest challenges that we see. People go on and off of Medicaid, and there are many times when we will enroll them and they are not eligible, and then lo and behold, a couple months later, because they haven't gotten their screens up front right away, we haven't been able to get them in, or they haven't been willing to come in at that point, then they become eligible for Medicaid, and they don't always inform you, even though we ask them to, they're not always informed that they're on Medicaid now. So it can get a little bit on the dirty side where you're having to, really clean up things.
Yeah, we've definitely heard that as a problem. And I think that some patients, they may not tell you because they really don't know that they have Medicaid. Yeah. So that definitely is one of the issues as well.
Hi, this is Susan from Prowers Medical Center.
Hi, Susan.
Hi. I kind of have a comment on your previous slide as well as this one. One population for us down here is our farmers and ranchers who don't have like a W-2 and they don't have a very standard flow of income. They can usually provide for me their last year's tax return to show income, which can either be in the negative or can be extremely low. So kind of in theory, I guess they're eligible for Medicaid, but they would never consider applying because their finances are too complicated for Medicaid's, formula of what you need to put in, and they're usually pretty kind of their cultural I guess their outlook on Medicaid would be that I don't want to give away all that information to the government.
Sure.
So I have those people as my clients. So that's kind of one answer to the eligibility. I am screening them. And then also another answer of that population would be those are people that if I can find them and get them in here, they haven't had anything done usually in quite some time. They really need to get it done. But I've just been trying to get, if I can get one person in, get them to spread the word, get your sister in, get your cousin, that kind of thing. So just to give you an idea about another population that I'm trying to tap into. And
Great.
That's great, Susan. Thank you.
This is Cynthia from Weld County.
Hi, Cynthia.
I just have a comment. We do occasionally run across women who don't want to apply for Medicaid. They just don't want to go on that kind of a service. So just, we do see those once in a while. And then my other question is, is there a place we should be recording this that shows we've checked for it? Other than that client profile tool, but like when they every time they need to, like when they come back in for diagnostics, it says we need to recheck. Where do we record that?
Were we going to add a checkbox, Anika? I can't remember. I'm sorry.
We're not adding something right
now.
now.
Okay.
It's really just us believing that you're doing it in the future. There could be a checkbox, but right now it's just believing, trusting that you're doing it.
And you may want to document that somehow. I don't know if your system already has some way to, I don't know.
Mm-hmm.
You can help us figure that out.
Okay.
Yeah. I mean, it does come up in discussions during, site visits and audits, but currently we don't have a place to truly document that right now.
This is Blair from Women's Health.
Hi, Blair.
Hi. I have a similar, barrier that I was thinking of, which is just figuring out a way to track when we're talking to people about Medicaid eligibility, just because I'm sure like all the other clinics, so many different people talking to them about their income and insurance, and so we're also kind of trying to figure out a way that makes sense for our workflow to track that, and I'd be curious to know if anyone has figured that out yet.
Question.
Anybody have any suggestions for Blair?
I know some clinics that's just the whole front desk every time kind of thing, but then it just doesn't work everywhere.
Mhm.
Hi, this is Darlene at Teller County. The only thing that I do is document it in the chart. It's kind of under referrals or discussion. As we're talking, I'm thinking maybe in a flow sheet check, in your electronic medical record or wherever, if there could be a checkbox about talking about Medicaid or referral to the ACA or whatever it is.
Mhm.
Right.
Yeah, I mean, a checkbox is usually the easiest way to go. It just depends on your particular agency and clinic on where that should be.
Mhm.
It also helps with those clients who are coming in more frequently and they're always declining Medicaid, so that you sort of know, like, we don't have to ask them every single time because we already know that they have declined it many times in the past.
Thank you.
So let's go back to question 2. What kind of relationships do you have with your local non-WWC providers?
So you mean so they might refer WWC eligible women, is that why? Or pretty much?
Yeah.
Okay.
So other clinics, other organizations that potentially have WWC eligible clients, does anybody have any relationships, special relationships with those organizations that could speak to how they get those eligible women into your WWC agency? And it doesn't have to be a clinic or anything like that. It could be a nonprofit or smaller community, nonprofit, could be a private practice that you've worked with.
So this is Nikki at Peak Vista in Kiowa. And we are pretty much, there's only one other clinic in our entire county out here, and she does not see Medicaid patients. And the relationship we have with them is anytime she has a cash patient, she does send them over to us for us to help with enrollment services. And, you know, if they qualify for WWC and Wise Women's, we get them taken care of. We also have like our local community assistance program. Their board members throughout the community are aware of our services, as well as our Albert County Early Childhood Council. So we've created relationships with groups that are involved in the school who, you know, with that they know kind of what families to look for. And if they see mom, you know, at parent-teacher or, you know, something at the school, they can say, hey, did you know Peak Vista offers these services? So we've kind of done outreach to other sources and solidified those relationships.
That's fantastic, Nikki. Mm-hmm. Was it difficult to get these clinics and other organizations on board? Did it take a long time?
No, it was immediate, and it was well embraced because, like I said, we're such a rural community, and we are there's only 2 medical clinics in our entire county, and we are the only ones that take Medicaid and then have enrollment for programs like these. So, you know, it was just such an easy partnership, and especially because we're working with our own neighbors, you know, it's not just, you know, here's a big, you know, here's a corporation within the community. It's, you know, these are actually my neighbors and, you know, people we see at the grocery stores. And so, no, it was just a very easy relationship.
Nikki, this is Shannon. Are you getting any referrals of clients from this clinic who may be insured with a high deductible at all? Or is that typically not?
No, typically not, but they are aware. We have given them information, you know, documentation and pamphlets and stuff about women's wellness, so they know what the criteria are. But most of the patients that they refer to us over are the uninsured.
Okay. Great.
This is Cynthia in Weld County. And one pocket of women that we have seen more of recently are the women who are involved with religious organizations, and they have what they call like a healthcare sharing program. They always indicate that they don't have insurance, and my understanding of it is that they pay into this group, and then after they have paid a certain amount, like a deductible up front, then they submit bills to this group who decides whether they want to help them pay for it. I don't know if others have heard of this. But anyhow, one provider in our area has quite a few of these type of patients and has referred several of them. And so I'm hopeful that we can eventually plug into more groups like this. I think that's like a little pocket of women who don't necessarily have insurance. They have some kind of coverage for catastrophical stuff, but anyway.
Great.
Yeah, we have heard of those groups.
Mm-hmm.
They sound like a pre-direct primary care type program. Any other comments or thoughts on relationships with non-WWC organizations in your area?
This is Jen at KHEP, and I've been struggling. I've been working a lot with the churches and other houses of worship for the Asian communities we service, but where I am getting success actually is with the mosque, the big mosque down on Parker Road. So it's not where I expected to do well, but they're starting to pick up on what I'm looking for. They're just sending people to us in general, but it looks like it could evolve into something.
Great.
That's great. What have you specifically been doing with the mosque?
Well, we were the main provider with the 9 News Health Fair there, and KHEP also does a series of fall health fairs, and the people at that mosque helped us organize ones at another mosque in North Glen, and then the one that's down on Birch and just south of Evans. So, I mean, it's been very light actually on the female turnout, but there are people who ask me questions in regard to sending their wives to me, and we are getting a van visit from St. Joe's to the mosque on Saturday, November 14th. And so far, it's a light sign-up so far, but we still have 4 weeks. And of the 6 or so I have so far, I think 4 are WWC. But Hannah, our Connect for Health guide from that community, is really actively working to get them signed up. So a couple of them may turn into insurance or Medicaid before the 14th happens.
Great.
Thanks, Jen. So we just have a few more minutes. We can move on to that 4th question, which is, have you already analyzed or have plans to analyze your client population data to see how it compares to either the overall WWC client population or the population in the client ID results? That's kind of a big question.
I know. So I guess the smaller question then is what kind of, how do you look at your own population data, and how do you compare it to larger populations, either like the state population or WWC?
Thank you. That makes more sense, Shannon.
And I'll just say the reason we asked that question is because the women we surveyed were not representative of the overall WWC population among all the agencies, and so it was a very different population. It was this mostly insured, high deductible, urban population, and we really wanted to know to see if you had been looking at your own clinic population in comparison to maybe overall WWC or outside of your area. So I know some people are.
They may not want to speak up today.
And it's okay.
It is okay.
You can let us know. You can email any of us with any of your thoughts.
And we know analysis is, when you're busy in your clinic, is really the last thing you are thinking about. You, most likely, a lot of our agencies don't have the FTE, or they don't have the dollars to do that as well. So if you're counting by fingers, by hands, however, you know, we want to really share best practices of what agencies are doing, from big FQHCs that have departments doing this to small organizations like KHEP. You know, there are some simple practices that if you send us some information, we'll share it with everybody as well. This isn't a requirement of our grant, but it actually helps you get other grants as well when you have data. So it's kind of a theme that you'll hear from us this year.
This is Nora. I'm willing to speak up.
Yay.
And I don't know that we've maybe analyzed it in maybe the way you guys are referencing. I know we've looked at it more from the standpoint of Medicaid enrollments and how this program and other programs have been affected. We do have registry that isn't totally complete. We're still kind of making some fixes, changes to it, and it is on pap smears. and what we're doing with that component. So we sort of do look at it through that section, and we've also looked at it from the standpoint of the impact Medicaid has had on some of our other funding programs. But we do have very large populations, so, you know, I can't say that we've totally analyzed every aspect of it, but we have looked at it. I've looked at it from the standpoint of, wow, how do we capture more women for this? Like, as you know, we were saying, we've kind of have changed our approach to really trying to educate other people that are coming in contact. You know, one of the things that kind of limits us a little is, you know, it's hard for us to enroll women in WWC if they don't want to get the services through us, because it's awfully difficult to you know, as you know, get access to the screening information and that type of thing. So, and we have enrolled women saying, are you at least willing to do these services through us? And then you can go back to your other providers. And we have managed to get a small percentage of them from that standpoint. And we're certainly not trying to draw them away from a different provider. But you know, we learned early in the whole process, in the first several years we were doing this, it was such a challenge to get copies of records. And we still have some challenges sometimes when we send them out for diagnostics. It's getting better, especially with the advent of the electronic health record. The process has become a lot more streamlined and smoother. But there are still times when we're saying, where's that surgical consult?
Yeah.
Those kinds of things. And where's the mammography if they've gone, especially if they've gone somewhere outside the valley? We do have women who choose to get their diagnostics outside of this area. And then it really, unless you've developed very good relationships, so for example, we have an excellent relationship with Parkview Hospital in St. Mary Corwin, but if they go anywhere outside of that, that's outside of our service areas, sometimes it's very difficult.
Yeah. Well, everyone, I think we have time for one more comment or suggestion. Well, thank you all for joining us for the HIT call today. Sorry.
Time for roadshow.
Oh, yeah. Do you want to talk about that?
You know, reminder next week, our roadshow starts, so we'll be seeing you all soon.
So our clock here is a little bit fast, I guess. But so if there are no more questions, we'll go ahead and conclude the HIT call. Let us know if you have any other questions or comments. You can always call us or email any of us. And we'll see you at one of the road shows. Thank you.